had enough of the sound of my voice, and then open it up for just discussions and questions. So just let me bring up my presentation and then share my screen.
And then, Dee, just a reminder that the slides aren't up on the screen right now. So,
yep,
great. I just passed the presenter ball.
Okay. So can everybody see okay?
Yeah.
Yep, perfect. Okay, so I always start by apologising somewhat for my accent. As you can hear, I'm not from Canada originally. One of my patients, when I started practice here, told me that I have irritable bowel syndrome. So I hope that I am intelligible to you. But I also have to acknowledge the wonderful welcome I've had on moving to Canada. It's a great place to be an immigrant, and you should feel justifiably proud of that. So primary care is the real world of research. It's where the action is, and most of the activity, in fact, in the health system happens in primary care. And as we know, there's the strongest evidence for an effect on improving population health outcomes comes from primary care. And one of the great things about working in clinical practice, I think, is that with every patient that comes through, research questions fly by. And there's never any end to the wondering that happens in clinical practice. And so that's where this title of A State of Wonder comes from. So I want to share with you what I think are some of the real opportunities for primary care research in medicine's next era, and what the challenges are as well. So this slide reflects a pretty typical Monday morning in family medicine. And these are actually a set of very real patients that have made me wonder over the years, and where wondering has turned to research and trying to answer the questions. Don Berwick recently has raised the idea that medicine is about to move into its third era, and he has called this the moral era of medicine. And I think medicine's next era is probably embodied in wandering around the last two patients on this list here. I know that many others are wondering about these same kind of issues or areas that we face in clinical care.
Sorry to cut you off here. There is a square on the screen from your video. Can you just move it over to the other screen so it's not? Just drag it over the other one too. There should be the video one there.
Okay. The video of me?
Yeah, that one.
Okay. This one. Oh, the video of me. This one.
Yeah.
Okay. There we go. Is that better?
There. Yeah. Thank you so much for that.
Yes. No problem. So I was just going to describe, before we think about what the third era is, it's useful to reflect on the first two eras. So looking at era one, that really reflected the rise of the medical profession with its roots back to Hippocrates, and among its norms are these: honour, special knowledge that's inaccessible to consumers, beneficence, independence of the influences of commerce and the state. And in return, society conceded to the medical profession a privilege, that was the ability to, and the authority to, judge the quality of our own work. However, the idealism of that era was really shaken by examinations that showed paternalism, enormous variation in practice, and injury from errors that were high enough to make healthcare a public health menace. Indignities and injustice related to ethnicity, social class, and profiteering. Era 2 really dominates our present framework for care, and it's really been about measurement and reporting and accountability and efficiency, based very much on models of efficiency and standardisation. It's also become characterised by a balance of specialism to generalism, and I think polypharmacy and its drivers provide a useful lens to understand the influences of the health system in Era 2, and particularly in primary care, to think about the conceptualisation of the third era and what the research and clinical opportunities are. So the problem is we need to talk about drugs, and it's not the drug problem we've been reading about in the media, but it's an equally big drug problem that probably represents the biggest opportunity we have to improve medical care in older adults, and particularly in the next 30 years. So meet Anne, and Anne is very familiar to anyone who touches primary care practice. She's 85 and she's had a fall at home, and you can see her medications on the right. This scenario is very familiar to any one of us. You or your mother or your father has multiple pills to take at multiple times of the day, and a blister pack might be used to try and reduce the confusion and keep things on track. But why is this a problem? Because these are good drugs that represent the advances in medical science. So surely if you need the pill, then you need the pills. But it's a little bit like music. If we listen to some Bach or some Miles Davis, some Leonard Cohen, Four Tops, or the boss, Bruce Springsteen, listening to them on their own, they do us good. They make us feel better. But what happens when we play them all together? Played together, they become a cacophony, and this is what it can be like for a patient on many medications in our current era. Here's an uncomfortable fact. In Europe, where we have the best data, more people die every year of drug adverse events than die of colon cancer or breast cancer or prostate cancer. It's the equivalent of more than a jumbo jet or two every day crashing and killing everybody on board. If this was an airline, would you fly on it? But our patients do every day. If this was an airline, the fleet would be grounded until the system was fixed. This cause of death and illness is really largely lost in our focus on epidemics of disease or the need to treat risk factors. In Canada, over 1 in 10 people on 5 or more medicines have a drug side effect that requires medical care each year. This is invisible in all our measures of care, and yet this causes more harm than many of the diseases that the drugs are designed to treat. But we have no measures in place to prevent death from this far more common cause. We know that more people in the US are now admitted to hospital because of low blood sugar from the treatments for diabetes than high blood sugar from the diabetes itself. And hypoglycemia is an outcome that really matters to patients, because even one significant hypoglycemia a year in type 2 diabetes increases the risk of dementia. Another study shows us that older adults on blood pressure medication are more likely to suffer a serious fall injury than their neighbour who is not. So here's a huge opportunity for gains for patients in this new era of care, and for health budgets as well, because $27 million is spent every year for every million older adults in the community in the annual healthcare costs of avoidable adverse drug reactions. But it doesn't really mean a new treatment or a cure. It's really about a paradigm shift, because medicine in the current era is all about doing. Whereas in medicine's next era, we will refocus on the art of not doing well. Polypharmacy is also associated with quite specific problems for patients. Polypharmacy makes people dizzy, drowsy, and dull thinking, with obvious implications for community mobility and social isolation. We see exactly the same thing in animal models of polypharmacy. Individually, the drugs are no problem, but combined in older animals, the burden of drugs results in reduced mobility, balance, and strength. And it's not just wasteful in terms of the harmful effects and the costs, but it wastes effectiveness as well, because when the number of pills gets so high, it leads to confusion, and it's often impossible to take them all, which could be protective, but in the chaos, the pills that get skipped might also be the ones that are really needed or the most helpful in terms of things that matter to the patient. And here's an example from a home visit we did about a year or so to a 72-year-old woman. And despite having a dosette, these were the pills that she was simply unable to cope with taking that we found around her house. The burden of care that we'd imposed was simply too great. There are also signals that these effects might be reversible. So in this trial a few years ago now, we took 70 consecutive older adults and we trialled stopping and then monitoring of all non-life essential medicines to see if they were still needed. But this is it wasn't an RCT, which we and others are doing now to try and determine to what effect and extent these effects are actually reversible if we reduce this burden. Polypharmacy also provides a lens on health equity. In reviewing the contributions that clinical care can and can't make to health equity in this paper we did a few years ago now, we suggested a list of potential system indicators for health equity. And one of the things that is sensitive across the lifespan is drug adverse reactions. Deprived populations are both more vulnerable to polypharmacy and also are least able to respond to adverse drug effects. We did a recent survey around eHealth, so there are other equity implications here. There's really great interest in the current era in the use of eHealth and simplifying management of chronic conditions for patients. But what do patients think about this? Because we searched the literature, we found that there are very few studies that actually asked patients what their views are of eHealth. So we asked around 800 consecutive patients attending our clinics here in our practice-based research network in Hamilton. We asked them whether they were interested in eHealth as part of their care. We also asked them about other things that might affect their ability to access eHealth. And of these 6 predictors that we found when we analysed them in the univariate model one at a time, when we looked at them all together in a multivariate analysis, there were only 2 things that predicted patients' interest in eHealth. One was obvious, it's the access to computer and the internet at home, and the other was being on more than 5 medications, which is a reflection of multimorbidity and complexity of care. So access, which is associated with both deprivation and low literacy, and polypharmacy, which is also associated with deprivation. As you can see, the inverse care law is likely related to increased health inequity for patients with polypharmacy if we apply eHealth models to chronic disease care. And these things, as you can see, were unrelated to age as well, so that's a very important distinguishing factor. Victor Montori has articulated really eloquently a new approach to medicine, which he's called, along with Carl May, minimally disruptive medicine. And this aims to ensure that the burden of medical care doesn't exceed the individual's capacity to cope. Yet we've really moved only from compliance to adherence in our paradigms of treatment and care. In Era 3, the question is, how can we move to self-efficacy and to patient-prioritised care? So I think examining the influences in Eras 1 and 2 that has led us to this current point will help frame our research wonderings and our direction for research and policy in Era 3. So this is the original conceptualisation of evidence-based medicine, in equal measure balancing clinical expertise or wisdom with research evidence. In parallel with Era 2, evidence-based medicine developed out of the pushback against the paternal professionalism, the variation, and to protect us against quack treatments, which were all very worthwhile and very much needed. But it's useful to reflect on some of the unintended consequences that have emerged in Era 2 now before we move forward. So EBM has really been captured to some extent by the accountability and market theory of Era 2 in a way that was never intended by its creators. It's been used as a tool for measurement reductionism and targets, and it plays into our fears as generalists of not knowing enough or being found in some way wanting. Single disease guideline-based care has really broken open Dave Sackett's original idea of evidence-based medicine. In Era 2, the evidence has become disconnected from those equally important domains of patients' clinical state and circumstances, and their preferences and actions, with the idea really embodied in guidelines, adherence and targets, that if care is standardised to doing what the research says, that outcomes will be better for all, and that important integrator clinical expertise has become lost. Where, like the Japanese car production efficiency models, the aim is for standardisation of treatment for each disease. Healthcare has become increasingly structured like individual production lines for all patients with diabetes or with heart disease, with the assumption that it doesn't matter who does it as long as it gets done, and that every patient, like every car, will be both perfect and identical at the end. But patients are neither perfect nor identical, and the combination of illnesses and their manifestation and symptoms is hugely variable, and they experience both these and the effects of their treatments inseparably and simultaneously. Like the oil in the engine mixing with the water of their radiator, this disconnected model of care, when converted into adherence as a target for care, doesn't work now for our patients with complex multimorbidity. This in turn has given rise to technovigilance as a mechanism for accountability, estimating the proportion of patients with a particular condition that are receiving treatment X or Z. And pay-for-performance schemes are increasingly popular in other countries. However, they've met with very mixed results and responses and intense debate. Targets are often surrogate measures, and single diseases rather than more sophisticated measures of primary care system function are used to assess quality. There have been very mixed effects on equity and access, and a negative effect on continuity of care and patient-centeredness has been seen, highlighting the real opportunity costs along with the lack of anticipated benefit on patient-relevant outcomes. Era 2 also increasingly reflects a time where commercial interests have begun to gain control of our body of knowledge and access to it. This bias becomes really concentrated in meta-analyses that can only see the published literature. And this is an example. This is the Cipriani meta-analysis that is often cited in the use of the newer antidepressants for depression. Now, this is work done by Eric Turner in 2010, and he worked for the FDA and their assessing committee, and he noticed that the studies that were submitted to the FDA, both published and unpublished, differed very much from what was available in the published literature on which meta-analyses are based. And his analysis, he looked at the studies of SSRIs that were in the published literature, and you can see here this looks pretty overwhelmingly positive for benefit from the FDA, from the published studies. Then he looked at all studies that were submitted to the FDA, both published and unpublished, and you can see here a very different picture. This is a really lovely visual example of publication bias. Now, there's nothing particularly special about SSRIs. It's likely that this kind of publication bias applies to all classes of drugs. And it's not surprising given the commercial driver for companies. There's no great incentive to publish studies that make your product look not effective. So these biases have become very much obscured in guidelines provided by specialist focus groups. And guidelines themselves have risen to a kind of status of some kind of sacred monster of medical care. We feel very uneasy if we don't follow them, even if we are making treatment plans most likely to improve the health of the individual with polypharmacy. But healthcare funders and administrators can often see guidelines as proxies for good care and their standard implementation as the best way to improve health. Here's a really well-known analysis by Cynthia Boyd of the way in which guidelines make polypharmacy inevitable. So let's take a woman of around 72 years and give her what a woman of that age might have. So two diseases that really interfere with her activities, osteoarthritis and lung disease. And because we as her good doctor did some measurements, three other diseases that we know about because of her numbers, so osteoporosis, hypertension, and type 2 diabetes. What happens if we apply all the single disease guidelines for these conditions? And it doesn't matter which 5 conditions you choose, the outcome is the same. This is what happens. So she ends up taking 19 doses of 12 different medicines, taken it 5 times during the day, with 19 non-pharmacological activities that we as her primary care team must try and persuade her to engage in, which take up her most precious commodity, which is time. Now, this example was published in 2005. The lag between evidence of effectiveness and evidence of harm as the medicines are used in our real world means that when I updated this for something else I was writing about a year ago, the number of opportunities for harm has now risen to 16. So 16 possibilities for significant harm for this individual. So we can see in this example the cracks in the current way of understanding good medicine. In Era 2, we've found ourselves in a predicament where it's perversely possible to provide what looks like care that's measurably better in terms of guidelines, adherence and performance, but can be meaningfully worse for individual patients. What this also says that is that in Era 3, for good medicine that is good for your health, you need good doctors. And because while prescribers are what turns chemicals into medicines, a wise, person-focused, generous approach is what turns them into good medicines. So a question for Era 3 is, do we try to improve guidelines for multimorbidity, or given the heterogeneous nature of multimorbidity, do we need to find a different way to synthesize knowledge? The disease-based vertical view that we have currently is congruent with specialist-focused models of care, but it's not congruent with the person-focused horizontal view that we see in everyday generalist primary care practice, taking into account all aspects of illnesses and context. And as a result, we see a lot of workarounds. And workarounds are a real gift for use in research and for system improvement, because they identify when systems aren't working, and they shine a light on the shifts that we're going to need at system level in Era 3. A further influence that's grown in parallel to Era 2 is what sociologists like Ulrich Beck have called the risk society. So during the industrial and modern eras, people grew confident that scientific and technical progress would enable humans to control the natural world and hence our own destiny. And in medicine, epidemiology can be used to create risk for almost everything, every single condition. And that's reinforced when government agencies use fear to try and drive behaviour like this. The sociologist Zygmunt Bauman summarised this really piercingly well. The big carcass of mortality has been sliced from head to tail into thin rashes of fearful yet curable or potentially curable afflictions. They can now fit neatly into every nook and cranny of life. Now the whole of life serves the purpose of war against causes of death. The permanent horror can only be dispelled in the bustle of doing something about it. The outcome is an excessive preoccupation with the risk of death, as if what was at stake was more than replacing one cause of death with another. So let's examine this idea of his. So this is a slide of most common causes of death since the 1840s. And there are two things you can see in these trajectories since 1840. The first are the enormous benefits of public health and medical care on preventing premature death from infectious disease. And there's no doubt that this has had an important effect and is an important and effective endeavour. But the second thing to notice is that at any one time point, all of these lines add up to 100%. We must all die of something. There will always be a most common cause of death. So as one disease fades, another rises to take its place as the most common cause of death. So if we think about the aim of prevention and identification of risk factors, the aim is to take this survival curve and turn it into a rectangle so that we as a population all survive to the normal life expectancy of a human body. But what happens as this curve becomes more of a rectangle, which is actually what we're seeing happen? What happens when we apply single disease preventions at the end of the rectangle? Is it possible that we're simply shifting one cause of death for another, as Bauman says? So if we take a metaphor for that, if we think of a car, or any car that I've ever owned, it goes along fine for a certain period of time, and then all of a sudden everything starts to go wrong expensively and seemingly almost all at once. And if we look at the example of statins to prevent cardiovascular disease in older age, we can examine this effect in humans. So if you look at the evidence for the only prospective trial of cholesterol drugs over age 70, the PROSPER trial, you can see here that it looks as though there's a reduction in cardiovascular death or non-fatal outcomes. So on the basis of this data, this was the interpretation by the authors of this study, that we should be applying this preventative strategy exactly the same way at the end of life as in mid-age. But what happens when we look at all-cause outcomes? So we took this data a few years ago and looked at all-cause mortality, which you can see in the middle there, and we see that it's not shifted, which doesn't actually matter, because if you reduce morbidity, that's also a really important outcome. But if you look at other causes of morbidity, in particular new cancer diagnosis and death, you'll see that they are increased to almost the same extent that cardiovascular morbidity is decreased. So you can see here that, in fact, what we're simply doing is shifting cause of death without increasing longevity and shifting one cause of morbidity for another. This is not special to statin treatment. You can see exactly the same effect with colorectal cancer screening in older age, which is why we have upper age limits for screening. Older age has many threats to physical and psychological well-being, and these are marvellous paintings from my high school art teacher, Trevor Moffat. Loneliness, boredom, that are not captured by disease rate counting. Are we further blighting old age with medical care? We're introducing the idea of risk to a person is a little like introducing a drop of black ink to a bowl of clear water. That clear water of the patient's identity will never be perfectly clear again. And this was illustrated to me very vividly when I was a resident. I had a patient, Mary, who used to come to me for her driving medicals. Mary was 89 and she needed her driving medicals to take Meals on Wheels to the elderly. Now Mary came to me one day after a short stay admission for a simple medical procedure. But during her admission, an enthusiastic resident had measured various things, including her cholesterol, and started her on a statin. And Mary was transformed when she came back to see me. She was worried and anxious in a way that I'd never seen before. She was worried about her heart condition. And this study from Scandinavia also demonstrates it really clearly in the data. So this is a study that looked at patients who had higher blood pressure, higher blood sugar, and abnormal thyroid function tests, and found that those who were aware that they had these diseases had poorer self-rated health than those who had exactly the same measures but were unaware of them. We're also unclear about what to do with risk in our aging population. We know that risk is different in old age, and this was a wonderful study a few years ago that took the famous Framingham risk score and used it to try and predict outcomes in those at high risk of cardiovascular mortality in 85 and over age groups, and found that it did not work in the same way that it does in the younger population. We also know that individual risk factors work differently, that the association of high lipids with mortality flattens out around age 70 and then reverses. We see similar effects with blood pressure and with blood sugar. And we know, as we discussed before, that hypoglycemia is a major threat to cognition in older age. But we continue to treat based on non-generalizable evidence. Therapeutic positivism also comes into play here, and here's a fact that I always find uncomfortable when I reflect on it, that most people that we're giving long-term medicines for are not benefiting from them, because in order for half to benefit, the number needed to treat must be less than or equal to 2, and it's rarely, if ever, that numbers needed to treat are in that order of magnitude. So This concept of technological brinkmanship was a term coined by an ethicist called Daniel Callahan from the US. All of us know that a point is reached where enough is enough, but no one is quite sure when that point is actually reached, and so treatments are continued and added until the end of life. So the second paradigm facing us then in this new era is countering this therapeutic imperative that runs through medicine, but without losing hope. Our medical system is predicated on doing things, and we have a desire to do something when a patient comes with a problem, to order a test, to give a treatment, by adding more and more treatments to a patient in their lifetime. And measures of quality of care are all about the number of times we do something. We have no framework yet for not doing things or stopping them, or for valuing these really important actions of care. So much so that it almost seems that we have forgotten how. And this example shows just how extraordinary that shift has been in Era 2. So this was a study of discontinuing statin use in people with late-stage terminal illness. And the results are not the unsurprising results that patient outcomes were better, but the clinician responses of those involved in the study. So this is from the principal investigator, who said, one thing we found during the study was clinicians saying, hey, I never thought about stopping people's statins in terminal illness. So this comment really illustrates just how far the pendulum has swung. So polypharmacy is a great marker for the cracks in the system in Era 2, like tidying up music into its component parts, as illustrated in this wonderful picture. When we tidy up patients into their component parts, this is what happens. The loss of meaning and context makes it impossible to hear the melodies of the patient's life and to provide care that will really enhance it. But are we brave enough to move from our comfort zone to address this? It will take real nerve and courage and innovative research and policy to leap into the void, to move forward from wondering what we're going to do to answering the questions of how and what we're going to do. So leaping into this void, Don Berwick calls this coming era the moral era. But I would call this the generalist era, because what we see here in these cracks in the system is a failure to prioritise and support the value of generalist primary care. Era 3 needs a rebalancing of specialist-focused care and generalism. It needs the rebalancing of risk and prevention and the shift to the centre of the person and not the disease. The way we assess treatments must change. The average number of medicines taken by people over 65 in most developed countries is now 7. We know that clinical trials don't include people with multiple illnesses taking multiple drugs. So we're really in the middle of an enormous global experiment now with almost no data collection. We've shifted our way of looking at treatments before in response to challenges. The first ever pre-market placebo-controlled trial of a drug was by Louis Lasagna in Rochester, New York. And the trial found that drug was very effective. Does anyone know what that drug is? So it was thalidomide. And the trial found that it was very effective. But the most important effects of thalidomide were only discovered later through doctors observing what happened to people in the real world. And this kind of observation will be vital in this next era. Our model of care is so focused on comparative effectiveness of medicines that, like thalidomide, we know little about comparative safety and efficacy in the real world of primary care, if and until we use the data from real populations in which they're used. Without this information, clinicians and patients don't have the information they need to make decisions about treatments, both starting and stopping. As a response to the problem of thalidomide, there was a massive shift in the way drugs were researched and licensed. This response to the prevalence of multimorbidity and the problems of polypharmacy create the opportunity for an equally massive shift. Primary care is the ideal context to provide the practice-based evidence that's needed. And some might say it's too hard to do drug trials, but I would say yes, we can. We just need to do them. We can also use practice-based research network data to understand more about polypharmacy, how polypharmacy happens, what the contributors are. So legacy drugs are drugs that are appropriate at initiation, but when prescribed for an intermediate kind of a period, so longer than an antibiotic, but not intended to be a life sentence. These drugs assume legacy status when we don't appropriately discontinue them after this intermediate period. So we looked at 3 markers of legacy drugs or legacy prescribing. Antidepressants, which are used to treat psychological symptoms, PPIs, which are used to treat physical symptoms, and bisphosphonates, which are used to treat symptomless risk. And this is what we found. So we used generous appropriate treatment periods of 15 months for antidepressants, of 15 months for proton pump inhibitors, and of 6 years for bisphosphonates. And what we found was that although in small proportions of patients there might be indications for long-term use, they don't approach the kinds of proportions that we saw legacy prescription in. So we found that for PPIs and antidepressants, nearly half of patients who had had a prescription for these drugs had them prescribed in an ongoing way beyond that intermediate period where benefit outweighs risk. We found that the mean duration for antidepressants and PPIs was approaching 5 years. And we found that of these patients, 60% were still taking them. So again, what this highlights is an enormous opportunity to improve patient care, because while audit and feedback mechanisms for improving care might be suggested in response, these are just workarounds. And my sense is that we become increasingly burdened with workaround lists of patients with oughts to attend to across a range of issues. So I think what this really shows us is that while our system is great at starting drugs and continuing drugs, we don't have good systems for stopping. And this is a real opportunity for system change. There is also needed domain-specific knowledge. So as a reaction to some of the difficulties, there's been a focus on a drug-based approach to trying to reduce the burden of medications and to try and improve appropriateness. And these kind of lists can be helpful tools, but they're not the answer, because it's still possible to be on 12 medications with none on these lists of potentially inappropriate medicines. They only predict around a quarter of hospital admissions due to drug side effects. And we lack evidence about the extent to which application can really improve outcomes that matter to patients. Like disease-based care, they still map awkwardly onto primary care. They're not responsive to the complexity and the heterogeneity of the patient with multimorbidity, nor to patient priorities. So there's work being done on how and when to stop medicines. But we need to really understand the system shifts in Era 3 that will avoid these problems even occurring in the first place. This is Jorge Luis Borges, a famous Argentinian writer of short stories, essays and poetry, and he was blind from early on in his life, and this gave him an extraordinary ability to see and describe things in a different way. And Borges wrote in a 1-paragraph short story, The Absurdity of Detailed Recording for its own sake. In Era 2, the requirements for recording has shifted from a way of recording meaning within the consultation to a line of defence and a method for monitoring that carries with it a certain loss of trust. These notes are often used as a proxy for what happens in the consultation, but we know that this map doesn't reflect the territory of the patient, nor the conversation of bearing witness to suffering or of nuanced discussions. The screen grab of Google Earth illustrates the way in which a complete technological map can still fail in rendering a complete truth. And there are no clouds or nighttime in Google's Earth. And understanding what makes a life worth living for patients. The answer to this is as heterogeneous as our individuals. In primary care, we articulate clearly the difference between the map and the territory. But in the map of the encounter between clinicians and patients, there is much recorded. If you look at your EMR, what is striking is what's visible, but what is not. There is much visible around disease measurement, but there is little of the person visible. We can assign you a code if you're injured by in a spaceship accident, but where are the patient priorities and preferences there is so much rhetoric around in our talk of person-focused care? the information that tells us for that patient what a life worth living really means. So here is one of our challenges, our ways forward. These wonderful and energetic people did a systematic review of the research literature across the globe, looking for tools that might help. They looked for tools that might be helpful in helping us to address patients with polypharmacy, to see what important priorities and preferences were to them and what outcomes were important to them. And in the end of all that searching of thousands of papers, all they found was one part of one tool that might be suitable. So we went to ask patients about their experience and how we might go about this. And this was pretty challenging, actually, to me, the data that we found. We found that clinician-initiated discussion of their preferences and priorities they experienced as rare, that their requests for medication discontinuation were largely either ignored or met with a negative response. And they highlighted the system issues of multiple clinicians and a lack of integration and communication within the system, which left them as the proxy communicator between clinicians, and a sense of powerlessness and anxiety that they felt, and fears for the effects of their care if they advocated for themselves. So these show the cracks in the system from the patient's perspective, both in primary care but also in fragmentation across the system. And this is their response to those cracks and fragmentation, was self-experimentation, not in partnership with their primary care or secondary care providers. So we need to understand and value the patient and the caregiver as the expert in both the observation of the effects of treatments and in what's important to them. They understand the necessity for trade-offs, but they need someone who is a coordinator for them, and they indicated that they wanted this to be a generalist. There's also a need for strong advocacy by or for the patient, because not everybody can be assertive, particularly when they're unwell. We need to give these experts the information they want. This website, which we developed a few years back, was designed to provide access to information to assist patients and help clinicians to recognise side effects. And it gets nearly 300,000 visits now per month. So patients are very keen and hungry for this kind of information to inform conversations. And in conversations with groups of patients here in Canada and back in New Zealand, which has mirrored the work of many others in trying to understand how to make these priorities visible. These were what patients told us were the domains that we should ask them about. Which are the things you'd like to be able to do that your health stops you from doing? Which are the symptoms that you most want your treatments to help with? What kind of things don't you want? And which medicines would you like to stop the most if you were able to? One of the system barriers is fear, because patients say, when we ask them, we'd like to take less medicine, we think your doctor's probably prescribed too much, and we think that stopping pills now and then, a drug holiday, is probably a good idea, but we don't start conversations because we worry about what you'll think, and we want to be able to restart a drug when we try stopping. Clinicians worry about giving the wrong impression by starting the conversation. We worry about the lack of a system approach for stopping medications and guidance in doing that, and we worry about not following single disease guidelines with the absence of any other system to approach reducing that burden. We've taken this work and the work of our feasibility study that I showed the results of earlier and used these building blocks to try and test a model currently that might be suitable for use as a routine prevention in primary care, and it's called TAPER, which is a team approach to polypharmacy evaluation and reduction. And the team in this case is a model that fosters partnership between the generalist primary care disciplines most interested in this issue, pharmacists and primary care physicians, and the crucial third partner of patients. It's supported by current evidence and tools for flagging potentially inappropriate medicines, but it's really driven by patient priorities, because addressing polypharmacy and multimorbidity is impossible without an understanding of patient priorities for care. And we're pretty excited about the emerging results that we've seen to date. But there are much more nuanced aspects of this to understand. The artist Kerry Skarbaka has produced a series of wonderful portraits of himself falling In the instance of slipping, he says, there's a moment of stillness just before you lose control. And this is a reference to the philosopher Martin Heidegger, who's described life as perpetually falling. The gaze of the falling man here could be on what he is about to crash into, or out to sea on the gloriousness of the view in the moment of stillness. And in some way, the idea of a life worth living is about focusing on the gloriousness of the view, rather than the inevitability for all of us at the end of the fall. In medicine's third era, how can we understand and value this beyond the reductionism of quality of life metrics? Young and Cullen made this observation in their work on death amongst East Londoners. There are indications that satisfaction, contentment and happiness are not related to the absolute level of health, but to the gap between expectations and reality. The work of chronic illness is relief of suffering to the extent that that's possible, but as often it is in helping patients to adjust their expectations so that they can be met, so that in that moment of stillness between slipping and falling they can focus on the view. There's so much still to understand about this and how to integrate that into individual care. At a system level, there are opportunities to align the measurement domains of quality in primary care in a way that they're congruent with the core aspects that we know improve population health outcomes, and that are congruent with a primary care generalist model and not with diseases or drugs. And there are people who are grappling with this thing across Canada. So just to finish off now, one of the things that I really love about Canada is skiing in the trees. We don't have trees on the ski fields in New Zealand, and so when I first tried here, I seemed to just keep skiing into the trees. And I talked to one of the Canadian mountain hosts in BC, actually, about this, and he said this to me. He said, well, it's because you're looking at the trees. If you look at the light between the trees, it will be completely different. And he was quite right. A new paradigm that is emerging from primary care is called Quaternary prevention, or P4, and this really shines light on actions to reduce the burdens and harms of excess care. How do we value and make this kind of good care visible in quality measures? How do we look at the light between the trees? Because between eras 1 and 2, we've moved from a high to a low trust system, where variation in care has been a kind of dirty word that implies variable quality. However, some variation is a healthy essential in translating the partial statistical lives of trial participants into person-focused care in the real lives of patients, to provide care that's best for them. How do we move to a system that supports both trust and quality? There are questions of balance between risk-mongering and our role in prevention, between data that informs and data that disables, between generalism and focused specialist care, between patient priorities and medical knowledge. We need primary care research now more than ever, because these kinds of cracks are a gift to us. Because as Leonard Cohen observed, there is a crack in everything. It's how the light gets in. So thank you for the invitation to talk with you today and to kind of share these views. And I'll be very interested in your views and discussion.
Awesome. Thank you so much, Dr. Mangin, for the presentation. It was fascinating. At this time, we're going to open it up for questions from the audience. So as you can see, I've muted you all on kind of entry. If anyone has a question, please feel free to either use the chat box by clicking the little chat icon next to your name. You can raise your hand just like you're in elementary school, and we will call on people that way. Or feel free to unmute yourself if you have a question and you'd like to ask it to the group. To start, does anyone have any questions? I'm also looking around the room in person in Vancouver here.
And comments as well. I felt like I posed all the questions, so I'll be interested to know if anyone has the answers.
I'll start actually. Thanks very much. It's Sterling Bryan here. I'm the Scientific Director at the BC Sport Unit. So thank you so much for what was just a tremendous presentation and such a thought-provoking one. I was just like reflecting, actually, like my stepfather, when he was getting towards the end of his life, he actually decided himself that he would just stop taking all of the medication, and he actually really enjoyed the last 6 months of his life much more than he had the previous few years, I suspect. So that sort of personal reflection just like seems to speak so much to what you're saying. I'm sort of, I don't know whether the name Scott Garrison is familiar to you and the work that he's doing in Alberta, but it seems very similar, and certainly he's got these real-world trials, pragmatic trials about stopping medication, and I think he's trying to do that. Some of the challenges that he's facing is to do with like doing that sort of work in primary care in a Canadian context. So some of the sort of like issues about can the system pay for consultations that are to do with research rather than sort of clinical consultation. But I don't know whether you're facing those similar challenges in your context or not.
No, we haven't. And in fact, Scott, I know Scott really well. We collaborate. He's a co-investigator on our TAPER trial as well. No, we haven't, because there is because the work of deprescribing is for our trial, the research data gathering is kept separate, and we do that for the patients rather than expecting any of the clinicians to do it. So all that the clinicians, the pharmacist and the family physician, are expected to do is the routine clinical work of assessing medications and making clinical decisions. So we provide the guidance support and some training. We provide deprescribing evidence and tools and guidance on taper rates and appropriate monitoring parameters and durations and those kinds of things. Okay. But we really, what my heart's desire actually before I retire is to have work like this embedded as just part of our routine prevention in primary care, that it's just what we do in the same way as we might offer influenza vaccination or pap smears. And so we really wanted to make this a trial of what we might do in the routine clinical context. So in that context, it's perfectly appropriate to bill for clinical work. But there are variations across provinces, and I think appropriate remuneration is one of the policy challenges and one of the things that we really need to advocate for. And really, I see research as a lever for advocacy. And if the results of this trial pan out the way that we think they're going to, I think that provides a powerful tool to advocate for appropriate funding models. But funding is different province to province, and I think it's a challenge in Canada. In Ontario, for example, there is a billing option that will allow for an extended consultation for this kind of educational and reflective discussion. In other provinces, that's not available. So I see that as one of our huge opportunities to try and, funding is perverse and provides perverse incentives, and I think there's an opportunity to try and align it with the things that are important in the primary care setting for patients with multimorbidity.
Great, thank you. Do we have any other questions, either online or in the room? Or any comments? Okay. Well, we're getting towards the end of the hour here, so if anyone has anything, let us know now or forever hold your peace. Our next webinar is May 15th on the ECOPS, the Electronic Communities of Practice for the unit. So be sure to check in for more details on that in upcoming newsletters. And a recording will be available online after. Dee, of course, we'll touch base about what slides need to be redacted and everything like that. But have a good afternoon, and thank you.
Thank you very much.
And I'll just comment too that I'm really happy to carry on the discussion by email afterwards if anyone's interested.
Okay. Perfect. Thank you.
Thank you.
Thanks very much indeed. Do that? Yeah.